Today's topic is heart failure, identifying the syndrome and burden of disease. I think you all probably know how big a problem heart failure is, but it can be very useful sometimes to understand just how much work there is that we are doing and what is the effectiveness of that work. And that all really has to do with the types and so forth of heart failure that we see, and we'll go over all those types briefly here, okay? And I have no disclosures related to this presentation. You should have all received learning objectives, but here they are once again. And we will proceed here. We'll start with a few questions just to see where everyone is with this type of knowledge. So if you do have the polling software ready, this will be the first question, and the polling is open so you can answer whenever you feel like you have the right answer ready. So first question, the increasing heart failure prevalence is mostly attributable to which of those things? Aging population, better antihypertensive treatment, more accurate diagnosis of heart failure, reduced mortality from a heart attack. And we'll give you a few seconds to answer here.
It's almost like 1 and 4.
There's only one correct answer. So go to rwbull.com and then you put in EW Echo. How many responses do we have? 8. Okay. We'll go on here in the interest of time and see our answers here. So most of you thought that aging population was the correct answer. So as we go through here, you can decide whether your answer was correct or not. Question 2, the modifiable risk factor most responsible for causing, or if we eliminate it, reducing the prevalence of heart failure would be which of the following? Diabetes, elevated cholesterol, hypertension, salt intake, or smoking? Again, just one answer, please. All right, looks like we have quite a few responses there. So hypertension, 60%. Excellent. Last question. True or false? Heart failure with preserved ejection fraction has a lower mortality than heart failure with reduced ejection fraction. Okay. 40-60 split on true and false. So we'll see what you guys think when we get to the end of the slides here. So, all right. So what is heart failure? Well, I think we all know that heart failure is a complex clinical syndrome, but that's not very helpful in sort of making the diagnosis. So what are really the things that we have to have in order to be sufficient to make the diagnosis of heart failure? And I think if you sat down and thought about this yourself, you'd probably come up with the same answer. It's one of two things, and sometimes it's both things together, which is insufficient cardiac output, or low flow out of the aortic valve or the pulmonic valve, or the presence of elevated filling pressures that are necessary in order to generate either an adequate or inadequate cardiac output. So those two things are really necessary to establish a diagnosis. And unfortunately, as you all know, when we look at these big databases from Medicare and so forth, we really have no measurement of those things. So it's really a little unclear whether a lot of the patients that we hear about in the epidemiologic literature actually have heart failure or not. And when we think about heart failure, I think it's also important to think about whether it's systolic or diastolic or both, and also to remember that there is a left and a right ventricle. I put the right ventricle on top here so we could pay extra attention to it today. And to be aware that either chamber can be affected by both systolic dysfunction or dysfunction of filling, or diastolic dysfunction. On the right side, systolic dysfunction can cause eventually decreased left ventricular filling, and almost always results in increased venous pressures. Okay, so this is your hepatic congestion, your profound lower extremity edema, that type of thing. If you have diastolic dysfunction of the right ventricle, again, you get all the problems with the elevated filling pressures, and especially with renal dysfunction, liver dysfunction, as those organs' drainage is impinged upon, as well as the extremity congestion. And I won't spend too much time talking about left ventricular dysfunction. That's decreased perfusion. We think about shock, of course, as any sort of end organ dysfunction. We all know that can sort of be chronic or acute, and that sometimes it's a very gray area which one you're looking at. But as well, we also see the result of this decreased pumping power is increased pulmonary pressures, which kind of gets you to the canonical congestive heart failure with pulmonary edema and difficulty breathing. When we have diastolic dysfunction, we see obligatorily high pulmonary pressures, and that this is sort of like the older woman who's short of breath, hypertensive, that would kind of fit into this box. And the usual things we think about there are dyspnea with exertion, where filling pressures get even higher and are felt even more acutely by the lungs, and in extreme cases, hypoxia. Okay. Now those things are sort of necessary to get the diagnosis, but what we end up studying are all these other things that we can measure a lot more easily, and a lot of these are kind of holdovers from past eras where people really relied on the physical exam to make these diagnoses. Okay. So, here are the Framingham criteria, and I'm not going to go through these other than to say, you see a lot of signs and symptoms here, and not a lot of objective information. There's no ejection fraction here. There's no measure of diastolic dysfunction, like the E to A ratio. None of that's here, but this is how heart failure was determined in the past, and as well as endpoints of studies now. We also see that these are commonly used to create those endpoints. And just to compare another set of criteria, you've probably heard of the Cardiovascular Health Study. And again, all signs and symptoms here. We also have the addition of some chest radiography findings, which are a little more objective than medical therapy. But as you all know, all these therapies can be used for multiple things. Okay. So we end up with this, if you look on the right side of the slide here, we end up with this kind of world of heart failure, but we can probably only identify a small part of it with our testing. And there's only a few databases that sort of have testing that would allow us to exquisitely determine whether pump dysfunction or high filling pressures are present. And if we compare those objective signs to the more of the criteria-based diagnoses, you can see that the correlation is really poor. So correlation here is 23% of objective signs to sort of more signs and symptoms that you get from physical exam or history. So we really have a poor handle, I think, on the magnitude of the problem to some degree, and we're probably underestimating it by quite a bit, because we don't do ejection fractions and diastology in all the patients that are in all these databases. Okay, so why do we care? Well, in the modern thinking of heart failure, we want to both prevent heart failure when we can, as well as treat it. And you have to have it be present first before you can do the treatment, certainly. So prevention, this is getting to the idea that, hypertension and myocardial infarction are really the two largest things causing a lot of the heart failure that we see. That's both diastolic and systolic. In terms of treatment, though, you want to be sure your patient has heart failure before you embark on, giving them beta blockers, ACE inhibitors, evidence-based therapies, and so forth. And I'm sure some of you are experts in devices. We don't want to be putting defibrillators and things like this in people who don't need them, obviously. So it is of some importance that we establish the diagnosis. All right, on to some statistics. Right now, we think that there are probably 6 million people in the U.S. with heart failure. I think based on what I just showed you, we can be fairly confident that it's even more than that. But they aren't all presenting to places where they're easily captured, like doctors' offices and hospitals and so forth. And the reason that heart failure prevalence is going to increase, and here up to almost 9 million by 2030, is mainly because of that orange line there, which are older people between the age of 65 and 79. So that aging effect is generating more myocardial infarction, more hypertension, more hypertrophy, more heart failure. So that will keep us all in business well into 2030. So, and you might ask, well, how much heart failure are we missing? This is some data from Olmsted County where Mayo Clinic is. And in terms of systolic heart failure, about 2% of all the people they did a random echo on had systolic dysfunction. So if we extrapolate that to the US population, that would be something like 7.2 million people. And we just told you there were 6 million that we know of from what are considered good studies. But already, if Olmsted County is any measure of the rest of the nation, and it's probably a slightly healthier place than, say, the Southeast, where heart failure we know has a higher incidence, we already get to over the number of heart failure patients we think are there. There's been this growing idea that we've done such a great job taking care of STEMI patients that now instead of dying, they have heart failure. That's probably a myth. You can see here that over time, as we go down on those lines there, over the years, there's less and less incidence of heart failure following myocardial infarction. And because myocardial infarction itself has declined, not just surviving it, but having it at all, we know that probably this is not true. It's probably not our interventional colleagues getting patients to the cath lab, although we appreciate when they do so, that has resulted in the increase in heart failure. It's really aging and poor treatment of hypertension. And which one is more, diastolic dysfunction or systolic dysfunction? I kind of wish it was systolic dysfunction because it's easier. We have more evidence for that. We know how to treat it. Diastolic dysfunction is much harder to identify and to treat. But unfortunately, it's about 3 times the risk or prevalence of having diastolic dysfunction than systolic dysfunction. And as the population ages, I think this is only going to worsen. So people who didn't have heart attacks are going to end up having hypertensive cardiomyopathies and end up with heart failure. And we'll have to deal with that. And which is worse to have, reduced ejection fraction or preserved ejection fraction? Again, I think this is data from Olmsted County, but both have a pretty high mortality. That's over 20% by 3 years. So that is not something that we can be proud of. That's something we need to work on. But heart failure with reduced ejection fraction is worse. I think you guys have probably all felt this in your practice. While it seems that the patients with reduced ejection fraction might get readmitted, you might see them a lot, so hard to take care of. Having a reduced ejection fraction is really much worse, and those patients do die more frequently at a higher rate. So that'll end the didactic for now. In summary, though, the exact incidence of heart failure is difficult, or prevalence rather, is difficult to understand given the complex diagnostic criteria. And when you hear 5 million, you should probably multiply that by 1.5 or 2 if you really want to understand how many people in the US have heart failure today. Risk factors for heart failure are age, most importantly, hypertension, also important because we can prevent this, and coronary disease, which we can also have some means of preventing. And risk factor reduction and early identification of reduced LV function are key because we'd really like to begin our therapies in sort of that AHA stage B of heart failure, where we may have a chance of really prolonging these people's lives for a long, long time into the future. All right. So, in the interest of time,
Okay.
we're okay?
Yeah.
So let me just go through the questions again here. So the increasing heart failure prevalence is mostly attributable to which of the following? We'll see if you guys learned some factoids here. All right, well, we got a few responses here going up.
Now we got 8.
All right, we're gonna go forward here.
Yay.
Excellent. So 88% with the right answer of aging in the population is the most common factor leading to the high prevalence. All right. And for the next question, the modifiable risk factor most responsible for reducing the prevalence of heart failure, which of the following? Diabetes, cholesterol, hypertension, salt intake, or smoking? Somehow we're not advancing here. There we go. All right, 100%. Perfect, with 9 responses. All right. And next, true or false, heart failure with preserved ejection fraction has a lower mortality than heart failure with reduced ejection fraction. %, say true. Awesome. So yeah, still very high for both though. Diastolic heart failure is not benign. All right. Well, thanks for that. We'll have a full set of references available for you to look at online once we're done getting all the little bits and parts of the procedure cleaned up. So you can see those there. If not, you can copy this down and go to this link and you can find all the references here. And with that, I think we'll be opening up to Peg hand